Good morning, ladies and gentlemen. Welcome to 23rd TCTAP 2018. I'm Do-Eun Choi from Yonsei University Severance Hospital, and on behalf of the scientific board members, I'd like to thank you all, distinguished faculties and attendees here, to join the meeting this year. We have a very interesting live case from Severance Hospital and Asa Medical Center this year, and more than 30 lectures about iliac to SFA, BTK intervention, aorta, and carotid intervention. I hope you all enjoy this year's TCTAP Endovascular Symposium and also your stay in Seoul. We're going to start from the live case from Yonsei University Severance Hospital. Thank you. And the panelists be joined and will be seated, and we'll start the first live case. Okay, let's start the live case session 1. And I'm Do-Eun Choi from Yonsei University Severance Hospital, Seoul, Korea, and my co-chair is Hiroshi Ando.
Thank you. I'm Hiroshi Ando from Kasukabuchi General Hospital. Thank you.
And we have a very distinguished discussant from the several countries. And okay, let's start the live case from Severance Hospital. Morning.
Morning.
Good morning.
Okay, we can see you and we can hear clearly. So let's start the first case, Dr. Davshi.
Sacker?
Yeah.
Dr. Sacker had some introduce our teams. And then
Sure, absolutely. Good morning to everyone. I'm Ravish Sachar from North Carolina. Pleasure and honor for me to be here today at TCTAP and at Severance Hospital. Chairman and panel members, good morning. We have a great case for you this morning. I believe this case, a patient belongs to one of the chairmen.
Yeah.
And so I think you'll be familiar with the case. I think it's an interesting case. You'll hear about it in just a minute. Dr. An will introduce the case, and Dr. Kim is joining us as well.
Okay, let me introduce our cases. It's very interesting. So next slide. Slide 넘겨주세요. Yeah, it's a 78-year-old female. It's she had a recently aggravated intermittent complications, Rutherford class 3. Actually, she received common femoral artery interventions in 2008. It's a very unusual lesions recently, but however, at that time there are some several regions we interventions at the left femoral artery, and then she had also hypertension and diabetes. And next slide. So recently performed the ankle Barker index shows the right side at 0.82 and left side is 0.5. The right side also had some decreases, and left side was very severe lasting pains and lasting and claudications. And next slide. So CT scan shows that very severe calcified regions at both common femoral and the right iliac, and there are some very total occlusions was a common femoral stent side, but it's not clearly visualized by the CT scan. But actually there are non-contrast area of left common femoral artery. common femoral 잠깐 멈춰주세요. 조금 더 아래, 오케이. Stop. 조금 더. 좀 더. Okay. There are very occluded segment at the common femoral stent side. And 2008, next slide. 2008, there are total occlusions at the common femoral left side, and then open the stent at the 7 by 6 millimeter smart stent. And then recently, 3 months ago, she aggravated the intermittent claudications. So, it's our cases?
Okay,
So,
the previous stent is 10 years ago, right?
Yeah.
Okay.
So question to the panel. Back 10 years ago, this was a common femoral artery stenosis, occlusion, no profunda femoris, and the decision at that time was to treat with stenting. Any thoughts on that? What would you do now? Would you do anything differently? What would be your approach to common femoral disease, especially occlusive calcified common femoral disease?
Okay. Any comment from?
Well, in our center, Ravish Lawrence Garcia, in our center, we've taken an approach for most CFAs that are calcified in some form of debulking, and in today's world with drug-coated balloon, it seems to be a nice combination. We're actually doing a pilot study of a prospective. We see a lot of retrospective reviews on common femoral disease, but we're really looking at this in a prospective way to compare it with a common femoral patch. Really to look at that kind of outcome. The stenting data, most of it's come out of Europe, and there's a single center series out of New Orleans which suggests that the stents, when they do work, they work well. When they don't work, they tend to go down as occlusions. So it'd be interesting to see how you treat this.
Yeah, absolutely. Same with us. There was a recent study, I believe, in JACC a few months ago, or maybe a year ago now, comparing, I believe this one was prospective, comparing a surgical strategy versus a stenting strategy. And so the only endovascular approach was stenting. And the outcomes in terms of patency were the same, but there was a 26% higher rate of complications in the surgical arm, suggesting that potentially in some patients, maybe obese patients, diabetic patients, there were wound complications, and which was probably the biggest downside to endarterectomy. It is a bit of a contentious issue, though, because for vascular surgeons, this has been bread and butter for a long time. The long-term data, if they get through the original procedure, index procedure without complications, looks very good. So to change that, I think will require the type of prospective data that you're saying you're going to gather. So that's great that you're going to do that.
I think in our center, we will prefer atherectomy with DCB for common femoral artery. And about the atherectomy device, we will prefer turbohawk over Jetstream because the lesion is limited and turbohawk can create larger hole than Jetstream.
Yeah, so we don't have any approved development device in Japan, so we have a balloon.
Okay.
Now, if you use a balloon and you don't have debulking available, would you, I don't know if you have any scoring balloons available, but any thoughts on scoring balloons if debulking is not available prior to a drug-coated balloon?
Okay. And did you check the by angio?
Yeah. So before the approach, so we also the ankle block index. There are some decreases on the right side, so we check the ultrasound for some right femoral artery. So right the common femoral puncture area. So increased area has some very severe stenotics. So we avoid the atheroma area. We check and the ultrasound, and then we approach the upper side of the atheroma, and we safely the access side the approach, and then we check angiogram of right side common femoral artery. So it's a puncture site angiogram 보여주세요. Yeah, right side common femoral angiogram shows a very severe calcified atheroma at the right common femoral artery also.
Okay.
So
Is that the routine procedure for by check the ultrasound before puncture?
So actually, our center had some. If there are some pre-procedural evaluation, there are some decreases also calcification or decreases the ankle plaque index, and then had some obese patient or some cases. We usually use the ultrasound for some initial puncture site evaluations.
Yeah, I think in this case, that kind of ultrasound guided puncture technique is very helpful for avoid the calcified common femoral artery. Yeah. Okay.
So how about the right common femoral artery lesions?
But I think today there is a focus in the left the instant total occlusion. So I think this right side, the common femoral, it looks also calcified region. So maybe next we're gonna treat it with atherectomy and balloon or something. But I think we'll focus on left side.
Okay.
So I think if the panel can keep this in mind, and at the end of the case, we'll go back to this and get a vote or a poll about what the best approach to this lesion will be next time to help Dr. An and Dr. Kim next time they're here.
Okay. Next, Amy. So we check a contralateral approach for some light, jocular light, and then the angiogram shows had a very severe stenosis at the external iliac artery, upper side of the stent.
Okay.
And then stent was totally occluded. So we guessed that this patient's symptom was aggravated by the initially total occluded stent area was not was compensated from the collateral circulation, but the external iliac progression maybe aggravated this symptoms.
Okay.
Yeah.
Yeah, initially we thought that maybe the common femoral stent was patent until 2 or 3 months ago when the symptoms started, which would be somewhat unusual. Why after 10 years it would suddenly occlude? But then the presence of this lesion suggests that maybe the lesion is new and the stent actually occluded a while ago. We can go on to the next one.
Next.
Okay, so here's the occlusion. You can see the proximal portion of the stent looks a little bit hazy, a little bit irregular, suggesting possible intraluminal filling defect, maybe thrombus there. The lesion extends beyond the stent and reconstitutes via collaterals, which are not so robust, about 1 centimeter or so after that. And interestingly, you may have picked up the first image from a few years ago. There's no profunda femoris that's been occluded for some time. So clearly this patient's going to be very symptomatic with this disease, multi-level disease, iliac common femoral, minimal collaterals.
So the patient's symptom is about less than 1 month, right?
3 months.
3 months.
2 or 3 months.
Yeah.
2
So-
to 3 months.
And you showed some haziness, so you think some part of the atheroma and also thrombus in the total occlusion of a stent?
Yes, that would make sense. And that's what we went into this with, thinking that this would be mixed disease with thrombus as well as atheroma.
Okay, next one. So we inserted the contralateral cis and then approached the regions from the proximal side of the stent. And then next slide. So we check again for some the collateral circulation, but the collateral flow was limited after after the cis insertion because of the external iliac artery stenosis.
Yeah. Okay.
And
After the information of this the angio, we will discuss about the strategy of the
Yeah.
patient. Any comment from audience, the panel for treatment strategy?
Thank you.
Okay.
I'm Dr. Gong, cardiovascular surgeon. May I talk about the discussion in the aspect of a surgeon? So, in summary, first, stent graft in common femoral artery, and the second, jailed DFA. There is occluded DFA. And third is the main cause of occlusion looks like there's something, the stent fracture. Stent fracture. So, so I recommend the surgical operation. For example, the excision of common femoral artery and the interposition of graft, because the cause of main cause of occlusion is stent fracture.
Okay.
So if you do something endovascular procedure, I mean the result may be not good, I guess.
Okay.
So I have some experience to excise the stent in common femoral artery. It is not easy, something difficult procedure, but many vascular surgeons can do it easily nowadays.
Okay, thank you. Any?
I think for this kind of lesion, we must be very cautious because maybe some thrombus content inside. So I will close the lesion and check the IVUS, then to decide which weapon I will use. Usually I will use a protection device like spider or NAP6, and then decide maybe I can choose laser atherectomy and orothorax also fine for this kind of lesion.
You previously mentioned you prefer the turbo, but this angel shows some thrombus container lesions. So you changed your the atherectomy device from turbo to jetstream or something?
Yeah, but for jetstream, I will have some concern because certainly jetstream is also indicated for ISR lesion, but we have the nightmare case when the wings up, then all the stents are destroyed. So especially for the stent fracture case, we must be very cautious about that.
Okay, how about Dr. Kalishian?
I like the thrombectomy approach with Jetstream. I think this would make perfect sense. And then Ravish and Dr. An, was there a thought, given the right common femoral, would you have approached this from a brachial approach? Would that have been an option with the Jetstream being as long as it is? I know the working length of Silverhawk to the common femoral sometimes is a challenge at 106 centimeters, but just wondering about that as an approach that would get you out of that right common femoral.
Yeah, the right common femoral, I think one option obviously is endarterectomy. If you're going to do an endovascular approach, you can't go from the left common femoral, so I think the left brachial approach would be the right way to go. There's a female patient, you need a 7 French system through the left brachial. That has potentially some challenges, but it's usually doable. Just need to be careful. And then once you get down there, I think either the Jetstream or the Hawk, both are long enough to get through the common femoral area. But the minute you get a little bit into the proximal SFA, usually it's not long enough. This patient does not appear too tall, so I think it's probably going to be okay to get to the right common femoral via the left brachial, and then the choice of whichever atherectomy device at that point.
Okay.
And as you guys get started, can I just have you guys comment on the, for in-stent restenosis, if this didn't have any evidence of thrombosis, would you need to debulk? And what I'm trying to get to is the global registry of impact, which from Marianne Brodman suggests that you don't have to debulk it and get a pretty good outcome on SFA disease. There's no data on CFA disease. But would you still have to go down that road, whether it be specialty balloon, debulk, to then eventually get to a DCB, or would a DCB alone? Again, taking out the thrombus part of this.
Yeah. That's a great question. So the ISR data from IMPACT, the global registry, looks phenomenal. In fact, this is the one of the times where, almost always you find that single center data looks a lot better than multi-center data. This is one of the times where it's kind of flipped. It's almost too good to be true. It's not that I don't believe it. I think it looks great. But I think whatever it is, it's going to be better with debulking. So I would still approach ISR, whether it's this one or long fempop disease, with debulking first, followed by DCB. I think it's good to know that just by DCB alone, the data looks so good. But I still approach with the debulking first.
Okay, go ahead, your procedure.
Great. So we've actually, we weren't sure how long this was going to take, and with a limited amount of time, we went and crossed the lesion already. I'll tell you the way we approached it. We used a stiff angle glide wire and a 5 French multi-purpose catheter. I'm not sure if we've got that image. We can move to that. And the initial portion of the stent went through very easily. It was very soft. So that was probably some amount of thrombus in there. But once you got to the mid-stent area, right around there, it was actually very tough to get through. It took quite a while, a lot of pushing, holding on to the sheath because it kept getting pushed back. And eventually, as you can see right over there, we made it through using a stiff glide wire and a multi-purpose catheter. So I think what we have here is probably distal common femoral ISR that has been there for some time, compensated by collaterals, and then the development of an external iliac stenosis, which then exacerbated the symptoms a few months ago and also resulted in thrombus formation in the proximal portion of that stent, if we were to put a story together with this.
Next.
Let's go to next. So as the panel has recommended, once we got through this, because of the thrombotic nature of this in the proximal segment and the large amount of neonatal hyperplasia in the distal segment, we did put a filter down. We chose to put a NAV6 7.2, and that is positioned in right around the P1 segment of the popliteal artery. If we go to the next one, we've got an image injection through the multi-purpose.
Do you check the IVUS after while crossing the lesion?
Yeah, we can do we have the IVUS open?
Yeah.
Why don't we go ahead and do that if we have time? Let's go ahead and do the IVUS. We'll see what it looks like within the stent and see what, whether the hypothesis that this is partially neonatal hyperplasia only and partially thrombus is correct. The remainder of the vessel looks great, as it did 10 years ago. Okay, next. We got the image with the filter.
Filter.
Right there.
Down.
Next, there we go. So that's where we are right now. So let's go ahead with the IVUS.
Okay, IVUS.
And our choice of atherectomy today is Jetstream.
The filter is the Endovascular, right?
This is the NAV6 EmboShield, that's correct. 7.2 size, 4 to 7. And we're getting an IVUS opened up here. We'll take a look at the common femoral stent, and then we'll move forward. Somebody had mentioned that there's concern about fracture within the stent, and with a fracture within the stent, the caution that was recommended with a Jetstream, any kind of rotational atherectomy catheter, I think that's well advised, and we'll be very careful as we go through it. And number two, I think a blades down only approach is probably suitable here. A blades up approach will probably be too risky and risk entanglement of the stent struts.
Hey, Ravish, while you guys do that, are you guys, beyond the IVUS, when you do the Jetstream, are you going to run blades down and then do a couple RX runs just to do some thrombectomy? Is that going to be part of your mantra, or are you going to do something just to debulk?
I think we'll start off by, once we get the IVUS, that'll maybe guide it a little bit, but the idea was to just start off with thrombectomy, blades down, do a couple of runs, maybe just one run, take a picture and see what we have, and then from there decide what to do next.
Do we see the profunda ever fill at all?
No, the profunda has been occluded since 2008.
Gotcha. So it doesn't even backfill from the distal vasculature?
No.
Again, the question back to a surgeon would be, if it did fill, I mean, one of the benefits of the patch approach would be to paneluna to the profunda. That would be one way to salvage everything.
How about the size of the Jetstream you preferred? You choose or after IVUS finding?
Yeah. You know, proximal disease, common femoral or SFA, usually go with a 2-4 and 3-4, and then decide whether or not to do blades up and blades down. When you get more distal into the popliteal, I think a 2-1, 3-1 is better. In this case, because we're not going to do blades up, and we have a common femoral, which is relatively large. I think a 2.4 to 3.4 would be a good choice, but I'd love to get the panel's thoughts.
I would think about because when the wings when the wings is down, the vessel Euclid is 2.4 millimeter, and when wings up, you will worry about a stent fracture or injury of the stent. So maybe other choice can be also considered, like the Rotarex or laser angioplasty as another choice of atherectomy device can create larger hole and more safe. Just personal opinion.
Those are very good points. I think you can make arguments for various types of atherectomy devices. Laser probably has the most data, and it's actually indicated in the US. The other ones, I think everybody's used them. The data may be a little bit less, but we get good results as well. I had a little bit of trouble passing the IVUS catheter through the distal portion, so again, suggesting that distal portion is the area that occluded first, maybe a long time ago, followed by thrombus later on. And we're beyond now. We're going to go ahead and start recording. Let's go live and record, please. Great. All right, I'm going to start pulling back.
Yeah, so given that calcium, although I like laser for the thrombus, it may not be very good for this kind of intimal calcium.
You can see a lot of plaque right there.
Yeah.
And that's all just
Look at all that
calcific
shadowing.
plaque. Yeah. And then gets a bit better right there. So you can see the stent is actually okay here. And soft plaque.
So there are a minor compressed area, but the definitely stent failure was not visualized.
Yeah. This actually is distal to the stent, the majority of the disease. This is the de novo new disease that, and you can see some possible thrombus here or soft plaque.
Okay, and I think the Y position is very good for in the about the middle of the stent. So I think if the Y position is the lateral side, it is very difficult to advance the Z3. So I think, but this is why the position is very good, and you can see clearly the large amount of thrombus.
Yes. So I think for those reasons, we have thrombus, we have calcium, and so the jet stream will allow for aspiration as well as treatment. So I think hopefully we'll be able to get a good result over here.
If you use a atherectomy device like a jet stream, so there's a possibility to stall when I touch to the stent segment, so the stent strut. Are there any risk of the stalling of the jet stream?
Yeah, I think the key here is to go very, very slow and use, what I always tell fellows is use visual, auditory, and tactile clues to know where you are. You want to make sure you can visualize the device away from the stent struts. You can hear it when it hits the stent struts, and if you're going slow enough, you have the ability to pull back. And you can also feel the vibration change if you do that. So I think all three need to be utilized when doing this. In fact, we'll mag up one more if you don't mind here, and if you go with LAO.
So what Ravish was just saying is really critical because, I mean, this thing is coming from the external to the common, so its angle is not great. And then you're going to be coaxial, at least you hope, as you enter the stent, but your biggest risk is entrance. Once it's inside the stent, there's no data on in-stent restenosis here. They may have some internal data from Boston, but the real question will be, does it capture and destroy the stent? Laser had direct impact to the stent tested by the FDA, and it had no impact. So it would be a lot easier with that.
So as you can see here, right immediately, it looked like I was close to the wall there, but it just centralized, telling us again that this is mainly just thrombus.
Yep.
And I've got plenty of room here. I hope that's visually clear to everybody in the room there, but we've got plenty of room. Getting a little close, but still okay.
And Ravish, as your IVUS had issues coming out of the artery, are you going to debulk that calcium for your DCB when you extend, or are you just going to treat with simple balloon?
You mean the area distal to the stent?
Yes, sir.
Yeah, we're going to, I think that's the area that probably needs debulking the most. It seems like that's where the de novo disease was that's formed over the last 10 years. So I think we should be approaching that right about now. And I suspect we're going to hear some change in pitch. Yeah, we can hear it now.
Dr. Ravishi, the next room are ready for transmission, so we will come back. It's okay?
Okay.
Okay, yeah. Next room, case number 2, Dr. Lee and Dr. Sin. We can see Dr. Lee. So can you hear me?
Hi, good morning, Dr. Chue.
Okay, let's start your case presentation.
Yes, I'll present I'll introduce my team. My team is Dr. Sin from 공단 뭐냐? 일산 보험공단 일산병원, and Dr. Bob. She's working at this hospital. So today we also have an ISR case, and Dr. Shin will introduce the case.
Good morning, ladies and gentlemen. I'll introduce our case. This is the ISR case. Next. This 81-year-old female have a resting pain of left foot. He already had several times of angioplasty previously, and he also had Severance disease. Next. She have pain on left foot, and ABR shows 0.34, very decreased. Next. 1 year ago, she already had an ISR intervention, and at that time, she underwent pamnitial intervention, and supera was implanted. Next. 3 days ago, we performed angiogram, and as you see, long occlusion was revealed from the proximal stent, and the reentry was distal pamnitial artery. Next.
No. Okay.
Yeah, as you see, the reentry was pamnitial artery, and so all the stent was occluded. So, is there any question about this case?
Okay, the stent cover the whole SFA, right? From the common femoral to near the pulpit artery, right?
Yeah, there are 3 Gilbert VTX from the proximal SFA to distal, and distal SFA to P2 level covered with a sulfur stent 1 year ago, one and a half year ago.
Okay.
I think because in this patient you have already tried Zilver PDX and failure, and then with Supera, a very nice stent, but still occluded. Then in such a long lesion, maybe a heparin coating Viabond will be can be considered, especially you have 2 distal runoff of the calf vessel, so the long-term patency seems quite nice.
However, this case covered with the stent covered with from the common femoral artery. So Viabond may block the deep femoral artery collateral, and distal landing is not so good. But pamnitial artery size is small, and distal landing is not so good. So if we put the Viabond intra-stent, that is another that will can make another problem.
Yeah, it certainly could. The issue is, I think that to the point, this is a drug-coated balloon, or excuse me, drug-coated stent, and then it failed, and a Supera probably is again hyperplastic. So it just takes you away from complete restenosis to edge restenosis as a potential. The reline study would suggest that that's a useful approach. But to your point, I think you're right. You have to then figure out where that stent graft's going to live. And if it comes close to the deep femoral, it really becomes problematic for the patient who, ultimately would fail with an occlusion. At some point, even at her age, you know, the bypass option is still very viable, and you don't want to shut that door with a stent graft.
Actually, I asked her symptom development, when the symptom development. So after the second procedure, she was doing well with mild to moderate claudication. But now, recently, she complained first toe region with resting pain developed within 1 week. So I estimated the lesion. Maybe some portion is usual ISL, but recently occurred thrombosis is not completely ruled out.
Okay. Dr. Chubakimoto, how can you treat this kind? This very long instant restoration.
If I treat this lesion, I also use a viable stent graft, but for common femoral artery, the positioning of viable is very important to avoid DFA jailing. So I carefully deploy the viable stent.
But in this case, the stent had already jailed DFA, so maybe it's difficult to put the viable in this case.
I'll show you today's angiogram. Anyway, I punctured the contralateral approach with this is JR catheter, next one. And after change of introduction of JR catheter, next, I changed the wire with amplatous positive, and I introduced 7 French ancelsis to the left external iliac artery. This is today's angiogram we taken. This is a landing zone of pulmonary artery. There is some spasm of pulmonary artery, maybe flow-mediated spasm, and the distal island is extended to the distal instant superior stent. So next. This is a proximal entry portion. There's a tapered end of the proximal SFA and total occlusion of whole stent.
Yeah. Go ahead.
So I initially tried with integral approach next with this is CXI 018 compatible CXI with commander wire. Because I assumed that this may be filled with thrombus, so I chose a slender wire, very soft wire. If it failed, I will change it to another stiff or 035 wire. Then distal reentry is very important. If the distal island, we already checked the distal island, so we have to the distal damage of pulmonary make another problem. So we have to keep the distal island to the distal landing. That is very important. If it failed, I am planned to retrograde puncture from the anterior tibial artery. Next, and anyway, this wire is very easily go to the intrastent portion next, and very easily go. So that is filled with thrombus, I think. Next, then very easily. But next, at the junction between Gilbert PTX and superior, there is some difficulty to pass because proximal stent is 6 millimeter, distal is 5 millimeter. There's a discrepancy. And next, and intrastent portion of superior is a little bit harder than Gilbert PTX portion. That maybe that is about some portion of atherosclerosis, neointimal hyperplasia maybe existed. Next, and anyway, guide wire were landing next to the anterior tibial artery. Next, so after introduction of guide wire to the anterior tibial, next, and CXI was advanced to the anterior tibial artery. Then I introduced the EMBO-shield filter device inside of the CXI guide catheter. Then I deliver the device at the P3 portion.
Okay, very good.
This is a procedure still I have done.
What size of this filter device?
This is a 4.7 larger size. Because Pamliteal is not so big, but I think there will be some flow mediated vasoconstriction. So I have chosen a bigger size of filter device.
Okay.
Sure. I think from your angiography, the superior stent have some problem over the proximal edge. So I think it is not deployed in a good way. So you can see the folding over the proximal portion of a superior stent. So maybe the cause of maybe in-stent restenosis or acute closure.
So I'm introducing a IVUS device to evaluate the reason, and this is a proximal, and it's maybe that is filled with thrombus with some plaque, and this is mid portion. Can you see the IVUS?
We cannot see IVUS. We can see
IVUS 좀 보여줄래요? IVUS. 스크린에 IVUS 띄워주세요.
Okay. We can see.
This is a mid portion. 엔조도 같이 띄워주세요. Okay, this is a Gilbert PTX portion, and this is a superior portion. This is maybe it's mainly with flat ABB, I think. Okay. 튜브 좀 돌려줄래 반대로? 오케이, 네이티브 포션까지 갈게요. 오케이, 여기서부터 저장할게요. 지금부터 레코딩.
This is distal part.
This is pamliteal, right? So pamliteal artery is small, around 4 or 5 millimeter with moderate plaque, and this is a distal native vessel, and I'm slowly pulling back there. This atheroma is also visible. This is a superior stent.
And the superior stent portion has a lot of neointimal, right?
Yeah, maybe that is neointimal.
Or
wire is located at the center of the superior stent.
Okay.
And slowly.
This is overlap area.
This is overlap superior, and from here, this is overlap area. And from here, this is a Gilbert PTX. Okay, there's some discrepancy of the stent between the superior and Gilbert PTX. 위로 갈게요.
Okay.
엔지오, okay. 좀 빨리 뺄게요. I will remove a little bit faster. And I think this is lumen is maintained here, but there is a moderate neointimal. Maybe this portion, maybe this portion may be filled with thrombus. 좀 더 갈게요. Okay, 그대로 있으면 됩니다.
I think the lesion is very, very long.
Okay.
Okay,
are there any comment?
Yeah, I think the Japan doctor has a lot of experience with IVUS. So, how about IVUS interpretation of Dr. Soga? What do you think about the IVUS in this patient?
Yes. IVUS is a very clear findings. So the distal portion of the SFA is a very tiny than expected. So less than 3 or 4 millimeter in the reference vessel diameter. Also the stent is a good expansion was observed from the IVUS. Therefore, so I am thinking so this instant occlusion is a very common instant occlusion. So what I want to talking about is which is the culprit of this instant occlusion. I am thinking that two portion is very stiff as a guide wire passage. The first is the proximal cap of the instant occlusion. The second is the gap or the gap of the superior and the ZPDX. I am thinking that the culprit of this instant occlusion is the gap of the ZPDX and the superior stent. Therefore, so if we can manage all these lesions, so I hope so you can treat this instant occlusion, I think.
And here I also have one question for Dr. Soga about the appearance of heparin coating via bond, since operators are worry about the Viabahn will cover the deep femoral artery, the deep profound artery. But how about treating with heparin coating Viabahn from distal to proximal SFA and just leave the 1 or 2 centimeters without further standing and use DCB for this kind of scenario?
I think so. The drug-coated balloon is much preferable in this situation because distal reference vessel diameter is a very, very tiny or small for a Viabahn placement.
And they also have some diseases in the distal popliteal artery.
Yeah, I think so. Very tiny or the disease, the popliteal artery. So if you can decide the rounding zone of the Viabahn, it's a very difficult, I think.
It kind of brings up the question that perhaps the length of stent notwithstanding as to a nidus or restenosis, but it seemed like the Silvers and possibly the Supera were oversized for the artery, so you get an overstretch model, which then lends itself to restenosis as well. So I think not only do you have lesion length working against you, but maybe it was oversized as well. That's maybe partly involved.
This patient, I would say, is very helpful for information. Huh?
Yeah, so the outflow looked like it was only 4 millimeters, but it's underfilled, right? So you don't know what the true vessel is. You never saw it at its inception. So it may very well be that the 5.5 was the right size for this artery, or that the 6 or 7s, whatever they used for Silvers, were appropriate. But it does become a bit of an issue when it becomes so truncated, kind of vascular tone is higher, that they look huge to that artery, and that might be, again, still a potential risk of restenosis.
In Korea right now, we have several atherectomy devices, but today, the 2 cases of ISR, we have the neointima plus thrombus, so I think this jet stream is very helpful for ISR lesion because it removes atheroma, also thrombus. So
how about Rotarex?
We don't have a Rotarex yet.
Dr. Garcia?
Yeah.
I have little experience with it, but
and turbo.
Yeah, but this might be, to your original point, it may be a really good use for laser, right? Okay. It's a lot of thrombus and a lot of intima, and it has the ISR indication, at least in the U.S. So, the data set on Excite was not great. Remember that it was just plain old balloon versus plain old balloon with excimer laser. And the primary benefit for the laser was 40-some-odd% on ISR. It was like 20-some-odd centimeters. But compared to plain old balloon angioplasty, which was 20%, that's how it got its victory. So, but its benefit with, they're now combining it with StellarX to do, they're trying to do photopack again. It really does kind of lend itself to this idea of combination therapy with ISR seems to be useful. But that might be the alternative thrombectomy and atherectomy device that could be useful here.
So when you use excimer laser, do you use a turbo tandem or eccentric device?
So they now have the Power Elite, which is this eccentric. So they put all the fibers on an outside, and they have the mandrel for the wire eccentrically positioned, so you can spin it. It gives you a little bit better swath because the vapor bubble is outside of that location. But we use that for our lasers these days.
I think both the Rotarex and the laser works very well in this kind of situation. But there is one difference is about the procedure time. I think laser is good, but it still needs longer procedure time than the Rotarex.
That's true.
So I'm doing a chest stream thrombectomy because this is filled with thrombus. I have chosen 2.1 and 30 millimeter both sides of a chest stream device. So I'm doing very slow advancement, less than 2 millimeter for 1 second.
Yeah. I think this doctor demonstrated very good example of jet stream, very slow advance, and if you feel some resistance, and also coming back with leg system. So I think that this is really demonstration, very good demonstration with jet stream.
And do you always use a filter device when you use a jet stream?
Yeah.
Oh,
because jet stream and also TAVR, we find that a lot of thrombus in the filter, so I usually recommend.
And how about the medication? I mean, during the procedure, besides heparin, do you also loading the urokinase or not necessary in this kind of situation? Because you say the symptom is acute for this case.
I have no experience loading a lytic on these. But I think I learned last year, I don't know if it was your case or somebody's, that for Pathway, they did a run and then they would always RX it. And I got to tell you, I incorporated it into my practice, and I think it's a very useful process. I think that was one of the best teaching points I learned in a long time.
Because for this kind of a lesion, if the symptom is acute or subacute, we will use the Fountain Cook infusion cast after the wire pacing and the loading urokinase, and then do the rotarex or laser.
Gotcha.
Yeah.
Well, you know, it's kind of funny. What's old again is new again, right? So the interventional radiologists for years would attempt these, not with stents at the time, but these would be occlusions. They'd always run lytic to unmask the lesion and then come back and fight another day. So it's probably a very useful way to do it.
Until this area, the sound is very uniform, but these are around here, the sound is a little different. There is some resistance, so there's maybe some hard material is filled with this area. So at this portion, advancement and slight retrieval is repetitively done to play the atheroma here. And the sound is better than previous one, and I will advance a little more. And blood color is changed from here to white, so that means that from this portion the fluid is not propagated to this portion. So anyway, I prefer to treat the proximal portion and a little then mid portion and distal portion.
Okay, Dr. Lee, keep going, and we will move and come back again, right? Okay?
Yeah.
Yeah. Yeah. Okay, Doctor.
Yeah.
Yeah, we'll come back.
다음 이미지.
Yeah.
Okay.
Yeah. Okay.
Explain your procedure.
Yeah.
Let's keep this up and we can go through the...
Yeah. Jet stream.
Okay.
So we performed the jet stream several times, the braid down and braid up to the inside of the stent. And
Yeah, so we went through this area here with the blades down all the way, and it made its way through that distal calcific area pretty nicely. And because it went so easily through the distal area and there was disease distal, which was not in the stent, we treated that last little area with the blades up approach as well. And so we did that, and then we came back and took a picture. So let's go to the next image. So this is blades down through most of the stent, and then blades up right at the very end. There we go, that's blades up right there. Okay, and then next.
Next.
And there we go. So that was the first image, and we'll let this run for a bit.
So there are...
Let's go back to that.
Let's
go back. Go back, right then, let that play, please.
Okay. Right. So there are some haziness there. The proximal portion of stent, and then there are residual lesions at the middle to distal lesions and the stent edges. So we decided to another jet stream atherectomy.
So we did another one, again, same thing, blades down for most of it and blades up at the very end. You can see a little bit of haziness at the end, and the result is here.
The blade up atherectomy also performed the proximal portions of stent in stent lesions. And then distal in stent and the distal edge of the native lesions, had many times we performed the braid down and up atherectomy. So we had a proceed the balloon angioplasty with drug-eluting balloons.
Okay.
Okay, next slide. So we 4 minutes of the drug-eluting balloon with size impact the 7 by 80.
680.
6 by 80. Because the IVUS shows there are edge of the stent, the inner diameter was not larger over the 6 millimeter. So after balloons, we get this image.
So can we get the last IVUS?
Last IVUS.
Angio result is quite good.
Yeah. And then IVUS shows some very good patents, and there are some.
So right there, what you see there is that's a competitive flow from the collateral right there. That's not thrombus, that's competitive flow. You can see that angiographically as well.
So the collateral flow was maybe formations by the proximal stent impaction of the external iliac artery. So there are very special images of the collateral flow.
I think if we didn't have the external iliac disease, we would not have seen that.
Yeah. Okay, and then we fixed next images. We checked the distal images. So distal SFA and popliteal had no lesions or embolic source.
And the filter is still in place where we had placed it at the beginning.
And then we fixed the external iliac artery with a self-expandable epic stent, and then adjunctive balloons, so 7. Okay, it's next slide. It's a self-expandable stent, 8 by 40, and then we balloons 7 by 20. So next.
Okay, next. Let's actually go ahead and get this
so
out.
we get a final images.
Let's take this out, the balloon.
Yeah.
I think in this case, after the atherectomy, you use impact DCB as your weapon. So do you consider other kinds of DCB, and is there any difference? Because while I ask is in Taiwan, we found a lot of no-flow, slow-flow phenomena, maybe the drug emboli, especially for the DCB use in BTK vessel. And we found Singapore have the same experience. And it is much better if DCB is used over the SFA area, but we still found some catastrophic case after DCB use. You know, after the atherectomy POBA, the image is quite nice, and after the DCB, and you see nothing. The flow does not go down. And some brands of maybe Lutone, we have impact. I think is a very good one. We don't have any complication for after impact DCB use, but in Taiwan, some centers, including us, have some no-flow, slow-flow phenomenon after Lutonics or Ranger DCB balloon use. So I don't know how about your experience in Korea?
It's very interesting. The data would suggest that for FEMPOP use, in the trials at least, while there may be a theoretical on-the-bench difference in the amount of debris that goes down or drug that embolizes, in the trials there's no real difference in terms of thrombosis or distal embolization or limb loss in FEMPOP disease in the large pivotal trials. On the bench, the impact seems to have potentially more particulate that gets released, but again, that does not translate to any kind of clinical consequence in the FEMPOP segment. So it's interesting that you're seeing the opposite of that. But I don't know, I'd love to get the rest of the panel's views on what device they would have used here and your experience.
Yeah, I'm not sure that there's much data out there. There's the global registry for BARD, and I think they're looking at an ISR. The issue with BARD, obviously, is that there's no data on CFA, so if you throw that out, just on the SFA, you know, their year 2 data hasn't been published, but it was 50-50 at the end of 2 years. The impact data now to 3, and then even 4 is the TLR rates are quite acceptable for femoral popliteal disease. I think the StellarX group from now Spectranetics has a pretty good opportunity to trump the BARD group and then probably be commensurate with impact. The issues are going to be what kind of patient population if you buy into this idea of their heavy calcific disease. So this may be one opportunity where StellarX may be useful based on their calcific layers or their data on that calcific data set. So, but I'm not sure that there's a huge shift, and I think Ravish is correct in the sense that I don't believe that there's a lot of femoral popliteal downside for impact. But again, I think that it has to be physically studied because that specific question has not been formally evaluated. The global registry doesn't support that it's a bad thing for in-stent restenosis, at least in that respect.
Ravish, very good demonstration of the in-stent restenosis treated with the jet stream, so with the TCV. And
I also wonder if there is a ratio difference regarding the no-flow, slow-flow phenomena after DCB use, especially in BTK region, because it seems popular in Asia, but every time during the meeting, I ask the doctors from Western country, they say it's never happen or rarely happen. Mm-hmm. So, but like our center, maybe BTK disease, maybe there is a 30 to 40% of no-flow, slow-flow after Lutonics using BTK.
Gotcha.
Dr. Did you see any thrombus material in the filter?
Yes. Very tiny maybe calcified atheroma was seen in the filter.
Okay.
Yeah, but it's not a big, large, but very large, tiny multiple. Yeah.
Can they focus in on this? There's some over here.
Okay. It's a very,
okay.
yeah.
Okay.
And
Yeah,
then at the distal tip of this, maybe a little bit as well.
Yeah.
But not much. Again, probably underscoring the aspiration feature of the jet stream device.
Congratulations, very good demonstration of instant restenosis treatment with atherectomy plus DCB. Thank you very much.
Thank you very much.
Okay, Dr. Lee.
Okay.
We moved and
Okay, let's stop 하시고요.
could you explain your case?
So, just small things that is gone. Anyway, we did jet stream device for the proximal, and initially we did blade down, but after several passages and use a blade up for jet stream thrombectomy. So anyway, there is some moving of the jet stream device. That means that area is minimal disease. So this portion is a suprastent portion, overlap portion of supra.
Yes.
And from here, I blade down initially, but there is some resistance between the junction between the PTX and supra. So there is some speed down sound. So I slowly did jet stream atherectomy, and then I removed the whole system and to check the angiogram, but still there is no reflow. That may be still not open the instant portion. 렉슨으로 다시 들어갈게요. 와이어 팁 보고 갈게요. Is there any comment for jet stream device usage?
So jet stream passed outside of the stent?
No.
No?
I just did only for the previous river PTX portion. And anyway, Goa graft is not available in Korea, so we don't have option for the Goa graft insertion, implantation. So the only option is a jetstream device, atherectomy, and DCB angioplasty. I think this is the best strategy for this case. We will see.
So
anyway, I will do a jetstream atherectomy several times from the proximal to the end of the CTO. Then final CTO will be opened at the last resort, for the last resort. So I will do several times more.
Okay. Keep going.
So have you passed the jet stream through the Supera stent?
No.
Not yet?
Just the beginning of the Supera stent.
Gotcha.
Yeah.
So
I will pass the Supera stent at the last.
I see.
After the several times of removal, and I will check the angiogram inside of the stent with micro suction catheter or some device to evaluate or I will check. I can evaluate the lesion with the IVUS study. Okay, before the opening of the whole structure.
Okay, we have time limit, so keep going, and maybe the result will be presented next live demonstration time. It's okay?
So it may be that they just don't have flow yet because they haven't crossed the Supera yet, right? I mean, there's still an occlusion down there, so I would expect nothing other than an occluded artery still.
Doctor, you worry about the Supera stent is 5 millimeter, very small, and a lot of neointima. So
yeah, you know, to the original question about length, you know, in the Superb trial, you know, we've shown at 1, 2, and 3 years now for the length of that data set that, you know, deployment matters with Supera, and if you do elongate it, it really works very poorly as a stent. If you compress it or it comes out nominally, it works very well for a bare metal stent all the way out to 3 years with TLR rates in the 90%, which is really nice on that randomized trial. But you know, if you don't deploy it well, then you run into this kind of thing. And I'm not sure if it's a size mismatch, as I said before, or not in this location. I think that may be part and parcel what created a lot of the restenosis.
Can you hear the sound difference around here? So there is some sound change with speed is dropped, slow drop. So this is there's some flap, hard flap located here.
Yeah. Our only anecdotal data on this has been we've run a laser for places that we've overextended the Supera to pop the artery behind it with microcavitation. The issue is that if you have a stent, a Supera stent that's anchored, even if you break the calcium, it will not release, and so it will not truncate in. And so you see that if it's just a solitary stent and it can actually then reform, has to be within a certain amount of time as well. But once it's anchored, even if you break the calcium behind it, it's still in this elongated state. It will not change its performance, unfortunately.
At the final angiogram, I will show you the intra-stent angiogram using a suction catheter. So we can check the anatomy of the intra-stent area because contrast injection from the guiding cannot evaluate the intra-stent area. So I'll show you the intra-stent angiogram. Next 할게요. 디스커넥트 하고 그렇게 누르고 계세요. 팁 보여주고요. 오케이. 석션 카테터 줘볼래요? 스탑하시고. 스탑하시고 그만하시고. DSA죠? Okay, I'll check the DSA angiogram first.
코로너리 석션 카테터.
네, 코로너리.
코로너리 석션 카테터.
네, 스룸버스터.
코로너리 석션 카테터. 이거 말고 코로너리 우리 할 때 석션 할 수 있는.
스룸버스터 없어요?
스룸버스터. 아니 이거 말고.
안지요?
듀얼룸에 있는 걸 봐요.
There's still no reflow. That is a usual finding after initial several jetstream atherectomy. 줘봐요. 이너 스타일에 빼세요. 석션을 한번 하고 합시다 그래도.
Yeah, this is a coronary suction catheter, right?
Yeah, yeah. 잡았어요? 오케이. 약간 아스피레이션 하세요. 한번 해봅시다. 뭐 나오나? 오케이. 당겨보세요. 지금 당겨보세요. 당기세요. 오케이. 나와요? 나오죠? 나오죠?
네.
오케이. 지금 나와요?
네, 피만 나와.
나오면 디스커넥 하고 엔조 찍고 컨트라스트 주세요. 여기다 잡아주세요. 오케이. This is a aspiration catheter is located between the junction overactive portion of supera and zilver PTX angio. Okay. Proximal part is also good. 잠깐 빼서 다시 한번 찍어볼게요. 그래서 the cause of no flow mainly at the distal part.
Okay.
엔조 찍어볼게요. Okay. So I will do a J-stream device several times more at the proximal part, and I will open the final portion at the last session. At the last session, okay?
Okay. This case session 1 is already the time is over, so your result will be present next live session.
Okay.
Okay.
Yeah. Yeah. Thank you.
Yeah. Thank you very much, Dr. Lee, and thank you all discussant. I'd like to close live case session 1 for instant resources case. Thank you very much.
Thank you.